Thank you, Professor. I'm going to talk about the psychiatric assessment in neurocognitive disorder, which it's now called neurocognitive disorder since 2013 when they introduced the DSM-5, although the former name dementia is still being used, as you've heard every speaker is using dementia, and hereafter I'll also use dementia, but if you come across neurocognitive disorder, they're simply referring to dementia. So I'm going to talk about a few aspects. For example, if you have a grandma at home, and you see her sensitivity to stimuli reducing, for example, her eyesight is not working as before, don't rush to say she's getting neurocognitive disorder. That is normal aging. There's also decrease in motor response. They are a little bit slow at picking things and passing on things. Even their processing speed of information is quite low. And also there is a decline in fluid intelligence, which starts declining in the third decade of life. What that simply means, your ability to process new information and solve novel ideas starts decreasing. However, the part of intelligence, which is crystallized intelligence, increases with age, which some people say, that's why sayings like, as you grow older, you become wiser. That's crystallized intelligence, but ability to process new information and, for example, giving your grandma an iPhone and you expect her to be able to go to hotspot. Your grandmother not being able to use hotspot on your phone, it simply means her fluid intelligence is low, but her crystallized intelligence is still okay. And when we say dementia, it's a disease process which is marked by progressive cognitive impairment in clear consciousness, which means if you have someone who has a reduced level of consciousness, the first time you're seeing them, you do not go and make a diagnosis of dementia. They should be clear, although what they may be saying might be different, but they should have a clear level of consciousness. When you assess the GS, the Glasgow Coma scale, it should be 15 out of 15. Then you can go on to say probably this person has dementia. Dr. Cadwell mentioned about this. What we assess are cognitive domains, which are quite many, but we look at processing speed, orientation of the patient, attention, memory, which is both immediate, short-term and long-term, language, visual spatial abilities, and executive functioning, all reasoning. And when we are talking to these patients, because as they grow older, sometimes they can't say what they mean. Like if you go to see a physician or a doctor, most times you give your information. But the sources of information for older persons changes. But even when the information changes, the primary source of the information is always the patient. Don't forget to talk to the patient. So the sources of information most times are the patient. Then you can talk to the attendant who notice all these things changing with time. She no longer remembers that go to the toilet. She doesn't do this anymore, but at least you've talked to the patient. And sometimes the attending doctors, they may be very keen to notice that decline over time, that she used to bring herself, now she doesn't remember where the clinic is and she needs to be brought. And usually history from multiple sources is very informative, because in psychiatry, we rely a lot on history. We usually take a very, very detailed history, because that is our main source of information, and that's what we use to diagnose most of the diseases. So there are many types of dementias, like Dr. Kadra has been mentioning. I'll mention briefly about each. What he has mentioned, don't want to sound so redundant, but I'll start with Alzheimer's, which is the commonest. So the presentation of Alzheimer's, when you hear dementia, the first thing that comes to your mind is the person forgets. So usually that is the earliest symptom of dementia, forgetting. And what they forget normal items, where they placed their keys, They forget appointments. Normal things, you know, she goes to the kitchen and forgets that the knife is very next to the saucepan. So it's a repeating pattern. And there's also, what I was saying is the increasing impairment in learning and short-term memory. That's the fruit intelligence bit. You tell her something like, lunch is in 30 minutes. She'll come and ask you after a few minutes, what time is lunch? They forget. You tell them something, they keep asking this. They may keep asking the same thing over and over again. Their speech, they struggle to find words. Like, send me that. She's struggling to find the word for sweater. So they struggle to find words, and their vocabulary keeps shrinking. And in the early stages of Alzheimer's, the patient is aware of what's happening. They are aware that they are forgetting, but they don't know why. And it's in this stage that they become frustrated, and they may come down with depression because they have really been struggling to remember, or they are struggling to put all these changes that are happening to them. Then these difficulties increase, the level of difficulty increases to the middle stage, where you have difficulties in executive functioning. Like if your grandmother used to prepare for you breakfast every time you went, this time when you tell her you're going, she doesn't remember what to do. She's happy, but she doesn't remember what to do. So if you're also not sure, you'll keep waiting for that breakfast, and it will never come. Abstract thinking also reduces. They find it difficult to understand new situations. If you bring her here, if she's used to being alone and you bring her here, she will not know what to do. She will be distressed, and she's just not understanding this new environment you're putting her in. They may also start experiencing personality changes. Someone who was always telling stories now is not telling stories anymore. So the grandkids who used to enjoy going to her to listen to stories, now they are like, now Jaja is boring, because she's no longer telling stories, and she gets annoyed easily. Simple things spark her off, yet she used to be very welcoming. Then in the later stage, there's profound memory loss, both anterograde and retrograde. There's poor judgment, disinhibited behaviors are common, like the case which was presented today, found wandering in the neighborhood, not knowing what's happening. She's just wandering. There's loss of insight. Sometimes there's loss of speech, spontaneous speech. You ask a question and they take a long time. If they are to answer you, they take a very, very long time. If you're not patient, the one we used to call it clearing lines. If you're one who clears lines, you'll have a very, very hard time. And in the later stages, there's complete dependence on caregivers. Why? Because the activities of daily living are gone. They just can't remember where the toilet is. They can't remember that when my bladder is full, I have to walk to the toilet. It's full, they just realize where they are. These memories are all gone, and they are really disinhibited. For Lewy body, Dr. Kado has talked mostly about this, but our case had hallucinations. Hallucinations are common in Lewy body dementia versus the other dementias. And like Dr. Kado said, if the dementia comes after Parkinson's, could be Parkinson's dementia, but also if someone with Lewy body dementia, they could develop symptoms of Parkinson's. So it depends on what stage or which came first for you to make the diagnosis. Then we also have frontotemporal dementia, which could have a behavior variant. where there's prominently personality and behavioral changes, or you could have a primary progressive aphasia variant where the major problem is language. Difficult finding words, difficult reading the word they know, difficult in writing the words they used to. So, and this is, you have degeneration mainly the frontal or temporal cortex. Then you have the vesicular dementias where you have, it could be a single infarct in the place which deals with memory, or you could have multiple infarcts, in which case every time they have an infarct, it's a stepwise decline. They have an infarct, there's a certain loss in cognitive function. They have another one, it goes down like steps. And then, like Professor Noel said, it's dementia is mainly managed by neurologists, but why do they come to psychiatrists? Because of the behavioral and psychological symptoms that are associated with dementia, and these are quite many. They could have disturbances in emotional experience, depression, apathy, delusions. Now, old people are very suspicious. One of the first things that appears is paranoid delusions. They become very, very suspicious. Where are you taking me? Are you sure I'll come back? So they become very, very suspicious of the people they know, of the events that are happening around them. And then there are also perceptual disturbances, misidentifying people. You've been replaced by someone else, so they call you someone else's name consistently. Not that they are forgotten, but they are misinterpreting you for someone else, so misidentifying you. Disturbances in motor function, circadian rhythms, they stay awake at night and sleep during day. Then appetite, they could, some eat a lot, some the appetite is totally gone. And why they come to psychiatrists? Because of the loss of the activities of daily living, which are mainly bathing. They lose they lose the ability to bathe themselves, dressing themselves, transporting themselves to and from places, taking themselves to the toilet, or even remembering that they have to go to the toilet, eating. Sometimes they do forget to eat and they just keep remembering that I ate. In general, when we are assessing patients with probable dementia, a longitudinal assessment is key. That means you have to demonstrate the cognitive deficits over time. A single sitting is hardly enough to make the diagnosis of dementia. And how do we assess them? Dr. Kadu mentioned this. We use mainly structured tools because then we can only be consistent when we use structured tools. And we commonly use the MINI, mental state, or the Montreal cognitive assessment. This is an example of MINI. So you have up there, you have dates, 1 visit, 2 visits, up to 5, and these are the cognitive domains they check. Orientation, registration, attention, recall, language, and copying. This is visual spatial. You tell them to copy the intersections of the two polygons, and like Dr. Kadu said, if you're not educated, this is very hard to do. And management, we mainly look at pharmacological, which Dr. Kadu mentioned. We look at behavioral, orienting the home. For example, instead of not having, not knowing where the toilet is, you actually put the label, toilet, okay? To help her with that. Those are all behavioral approaches. And then, as we know, family. We have to address the family issues. One, they have to know that neurocognitive decline is irreversible. And 2, during the late stage, they are totally dependent on their caregivers for everything, from showering to dressing to feeding. So the caregiver has to know this, and they have to decide what they are going to do as a family. And then in the later stages, it's quite controversial whether you use medication or not, because as Dr. Kadu was saying, if the neurons, the medications are targeting are already damaged, so then why are you giving these drugs? But still, that's a decision you have to discuss with the caregiver. And finally, these are a few things about our patient. As we were going, I was mentioning them. One, she had memory loss, which we said, the earliest symptom. And then the speech worsened, and then she developed tactile and visual hallucinations, at which point she was started on anticholinergics, and then later lost the ability to perform the normal activities of daily living, like going to the toilet. So, thank you. That was all the time I
had. We thank Dr. Apollo for his presentation. I think it was very good. Do you have any burning questions? Yes, please. Right. Any other question? Yes, please. It's long-term memory. Professor Neti?
Yes, I just wanted to know the average time from start and miles since the natural history.
Right. Okay. Right. Any questions on this side? No. Yes, please.
Over 66 dementia and then because it's more, it's better in our setting who I know and then secondly, there seems to be no one talking about young onset dementia, which is already coming up. We are having patients who are 45 years already getting dementia, yet most people most of the studies done after guys who are 65 years. I don't know if
No, it's not working. Thank you. I'll respond to some of the questions, the rest I'll refer. Like we are told, if you can't manage, you refer. So, I'll start with the mini mental state exam. So yes, it's a tool we use commonly, but it has its limitations. For example, if you're telling someone has never been to school, who can't write their name, to copy the intersections of a polygon, then they are going to score badly on that. But there are other tools we can use depending on who is in front of you. Okay, so the tool you use depends on who you have, and there are quite a number of tools. Long-term memory is also affected, especially in the late stages of the disease. Long-term memory is affected as well. As for young early onset dementia, the average age it's different for each type of dementia, but averagely speaking, it's 65 years onwards. But there are those who have dementia earlier, and cases have been presented. We don't know if I don't know if anyone has come across them among our lecturers and professors. As for the natural history of the dementia, Alzheimer's, I'm going to refer to Professor Noe. Thank you.
Okay, so before I answer the referred questions, when Dr. Apollo was presenting, he kept on saying she. And my neighbor asked, does it always have to be a she? What do you mean? I'm pointing because you finish your rotation in psychiatry. Does it always have to be a she? Does it have to be a she? Why do you think he's finding it easier to say she?
Because the case was like
Because the case is referring to a patient, but it could have been a male presenting. So what is the ratio of male to female for people who get Alzheimer's disease? Is it the same or is it different? How? It's more in women. So, yeah, it's more in women. So I will answer some of these questions. The natural history, Professor Biantica, the natural history of Alzheimer's disease, the books used to say that from the time of onset, you wait about 8 years before the person may pass on. However, it's also rather very difficult to ascertain the actual cause of death for people who may have had a diagnosis of dementia, because there are always so many other comorbidities that come in that eventually may lead to their demise and not specifically the degeneration of the brain. However, as Dr. Polo said, everyone has their course. There are some people whose course is rather very fast. In 2 years they deteriorated so much, while others it's a rather slower process of deterioration. But then the risk factors that Dr. Kadi talked about also become very important. Your education and how well you've been feeding, how well you've been exercising, then become key in sometimes for some of them how you deteriorate, or whether you have other risk factors, hypertension, DM, smoking, and all the others. Now, as regards the instruments, the MMSC may not be ideal, but you can adjust scores. So there's literature to show that you can adjust the scoring for people who are coming from resource-limited settings, so that you are aware that where the task you've given requires a higher level of education, you either, if you're screening like a group of people, you cut that out for everyone so that you're giving an adjusted score. There are instruments like the 1066. I use the 1066 in Wakiso, but as I pointed out in the beginning, still we found a very high prevalence of about 30%, which is not kind of acceptable, because the acceptable rate of dementia in the community should be about 5 to 10%, not 60%. There are early forms of onset for dementia, and there are various reasons. If you're looking at neurodegeneration, there are other neurodegenerative processes that can go on in individuals. As regards dementia, it's usually the frontotemporal dementia that may present much earlier than the 65 years of age that Dr. Polo is talking about, with changes in personality and everything else that comes with it. There are other causes. I think there was the mnemonic on possible etiologies, trauma to the head, other infections, HIV, crypto, anything else can cause you to get your cells dying and therefore degenerating. So there are other earlier forms of neurodegeneration that one has to consider, but not specifically for Alzheimer's. But there are some people who do get early onset Alzheimer's disease. I think those are the comments that I wanted to give. And now I wanted us to move on to the next part of our presentation. We are honored this afternoon to have two geriatricians in the audience, Dr. Harriet Nankabirwa and Dr. Otim Robert, for the people to see you. So we are going to hear from Dr. Nankabirwa some comments about